Perfect. Yeah, so let's get going because we have a lot of things to talk about. So I'm Patricia Tellez-Giron. I'm an associate professor with the Department of Family Medicine and Community Health, the co-chair of the Latino Health Council, and the founding president for the Medical Organization for Latino Access Wisconsin. That is an organization that one of the main focus is working with the students so that they can be successful in their health careers. So that's a little bit of me. I have a family on the side and have a couple of sons. And I think that one of the main reasons of why I do what I do is because I have had very good nurturing mentors through my career, and they have really made a difference. So I really thought that I needed to pay it back. But when I think about mentoring, as you see the definition, to me, it's just very limiting. So I call what I do more of a nurturing mentoring. And for the ones that know some of my students, you know that I call them my chickens, so my pollitos, and I'm kind of the mom hand that covers them with my wings and try to help them with not only the regular mentoring and how to get shadowing or community work, but it's really much more working on the nurturing side of realizing that before they were in pre-med or med or residency, they had a family, they came from a culture and a community, and they really need a lot of encouragement and care and support. As a matter of fact, I just came from having breakfast with one of them that is considering not continuing because she feels that her family will not be supporting her because she should be working and helping for the household. So the kind of issues that the students that I work with are very close to the issues that I faced when I was, studying to work in the United States. So I feel very blessed to be able to know and understand where they are coming from. I started doing this basically empirically even before I started residency. And then through residency, and then it was just natural as a faculty that I will continue what I started. So who is that I have been nurturing? A lot of the URM students, mostly Latinx, but really anyone that needs help. I have students that are from the Black community, the Hmong community, the Vietnamese community, the white community, basically anyone that comes to me and asks for help, I try to help. And we are now down to helping students that are all the way down to even high school or even before that, pre-med, med residency, faculty, and I also mentor international medical graduates. Right now we have Carmen at our clinic at Wingra that we're really trying to get up to speed because she's going to start family medicine and she was an OB-GYN in Venezuela. So basically anybody that needs help. And I am just so proud. I was thinking yesterday because Tom is now gonna be our residency director and he was one of my students. And I was just thinking, oh boy, I wonder what he was thinking when he was a resident and thinking, would I one day be a residency director? And, Kirsten Reinfleisch and Morgan and many of, the faculty that I am so proud that I have, been in their life at least for a little bit. Why I do it again? Because through the years, I have gotten more experience. I have talked to many, many students and learned more about what is that they need. And through that, I have learned that the regular system is not really fulfilling the needs of many of the URM students because the system here is very individualistic and many times does not take into account the cultural differences that some of these students have, their immigration status or the immigration status of their families and how that influence completely who they are and what they need to do. My student has a mom that is working in a factory, and she was telling me she makes $9 an hour, and it's like, how is she able to support her family being a student here? So definitely there are huge financial differences with the students that I see many times. Like, again, this student, when I invited her to breakfast, she said, I can't because I don't have money for breakfast. And I said, don't worry, it's on me. History of trauma. So many of them come with a story where their families had to go through a lot of things or themselves, and how is that also plays a role on how they see themselves and their sense of belonging to this system. And then racism, definitely, that is influencing. So all of these things is where I see that I see the difference with when I mentor Y students compared to URM students. How do I do it? Any way I can. So I do it one-on-one. I do presentations in a group. We do a lot of education, but a lot of modeling as well in the clinic, in the community. I try to guide them to the requirements that they need and other things. I connect them with other people. But I think my most important part in their life is the caring for them at a personal level, because they definitely need to connect with someone that could understand and that could take a text anytime during the day or the night if they have any needs. And who do I do it with? So I have a huge, team of members that contribute. Manuel Santiago with the medical school, Shiva Vidarsi Lab, my own family, my partners at Wingra. I also teach them that they have to help each other, so they have to lend a hand to the ones coming behind. So every time I have a student that has a need, I send an email, and I love that the students reply right away, how can we help? Because that's what I tell them, that, the only thing that I ask them is that they will help the one that comes behind. The Department of Family Medicine and Community Health has been an amazing partner. I really feel very blessed to be in this department, because since day one that I joined as a resident and then as a faculty, I have always feel welcome and supported. And most recently with our program, Enrich, and we have to talk about Enrich, because I remember clearly how Morgan and Estefan and Tom came to me and asked me about what I'm presenting today. And they were like, you know what, wouldn't this be amazing to have a program, a formal program like this for the department, so that we can increase representation from the URM groups, maybe from pre-med and med, and then they can come as residents, and then they can be faculty. And that's how Enrich was born a couple of years ago. And this program aims to give all the nurturing tools that I told you before to underrepresented students to be successful in their careers. We would love it if they stay with family medicine, but we know that even if they go to a different specialty, they will be fulfilling the needs of the underrepresented communities. So we're gonna be there for them for 4 years or even more with my pollitos. I have been in their life with some of them for 10 or 12 or 14 years, and I'm very happy to be there. So Enrich, we're gonna have a lot of pollitos that might be graduating and then going to residency and then coming as faculty or staying for all this time. We are supporting them with resources so that they can go to conferences, they can do research during summer. We offer networking events where they feel important and that they belong, to be able to have experiences like yesterday, to go to a restaurant that maybe they were not able to afford until maybe in many, many years. And for them to see that it is worth it, right, to continue the sacrifice and the investment that they are doing, because it's going to pay it off in the future. So I am extremely thankful to Tom and Morgan and Stefan to invite me to be part of this team, because it's really my dream to be able to have a team like this to fulfill the needs of the students that I work with. Latino Health Council also has been an amazing partner. We support a lot of the pre-med students with many, many needs, including rent assistance through COVID because they couldn't afford it. And now with MOLA, we're going to create a formal organization that is going to be able to have more mentors and more resources for the Latinx students, and it's going to be formalized. So I am so happy to think that I have been at the department for 26 years and to see all the changes that are happening in the positive side. So thank you very much.
Excellent. I'm just going to chime in quick. Thank you, Dr. Tellez-Giron. We are going to do questions at the end. So if you have comments or questions, feel free to put them in the chat and we'll cover them after everyone has shared. So we'll move on to Dr. Landeck, who's going to talk about some of the rural pathways in our department.
Yeah, great. Thanks so much. I was really excited that you asked me to join this panel. This is a big passion of mine in getting to work with residents who have interest in going into a rural career, and more and more, I just love finding ways that we can recruit more rural family physicians and retain them to serve their communities. So it's the reason I joined the department back in 2017 when we created the Rural Health Equity Track through some of the great work of other folks in the department before me. And I've been able to be involved in a few different roles around rural medical education. I serve on the admissions committee for the Wisconsin Academy for Rural Medicine, or WARM. I grew up in a small town, about 800 people year-round population, and I always think it's kind of a happy accident that I ended up in medicine, because I really didn't have any role models. Our closest physician, who I never saw growing up, was 45 minutes away, and really didn't see myself becoming a physician until I was almost finished with college. And so I love getting to meet younger learners who may not even have this on their radar as I didn't. So you can go ahead, Patricia. Oh, maybe go back one slide. Yeah. So rural pathways are really important. We really have a rural health crisis in this country. And rural hospitals are closing at really staggering rates, especially in certain parts of the country like the South. And that's due to, several factors, low reimbursement being the main one, but strong workforce is also a major factor. So it's about 26% of Wisconsinites live in rural areas, but only 7% of physicians work in rural areas. So a huge disconnect. And very few medical school graduates are from rural backgrounds, and we haven't made much progress in this area. So that's why programs like WARM are so important. It's only about 4.3% of medical school graduates from a study in 2019 were from rural backgrounds. And health outcomes are worse in rural areas, and access to care and an adequate workforce are a reason for that. People of color living in rural areas have worse health outcomes as well, and so there's a huge need for stronger representation from URM students and physicians in practice to help to address that. And it's actually only 1 in 200 incoming medical students are from rural URM background. You can go forward. So huge believer in effective pathways starting early. So I haven't thus far personally had a lot of experience working with middle school and high schoolers. We have connections to the Belleville School District and some of the other local school districts in Southwest Wisconsin, but there are various models for effective early pathways that exist some of the ideas being borrowed from urban pathways, but there's some great programming out there. And really the strongest, well, the second strongest predictor of being a physician that goes into rural practice and a physician that stays in rural practice is being from a rural background. So we really need to grow our own, if you will. Actually, the strongest predictor is your significant other's preference. And in my experience with the Rural Health Equity Track, that's essentially been our experience is that the folks that didn't end up in rural practice that maybe intended to first, it's because of family choice, which is understandable. So AHEC has fantastic programming that targets down to middle school age students. And this is a list of their various programs. They have regional centers throughout the state. And I've done some teaching with the AHEC Scholars Program around substance use disorders. So if you are in a rural area practicing or know of younger students, AHEC is a great way to get exposure to healthcare careers early on. And NACHIP has fantastic programming as well for similar age students and provides a lot of scholarships to medical students from Native backgrounds. I mentioned WARM. With support from SMPH, WARM has expanded their class size over the past couple years, which is exciting. And they have a great track record of getting docs into rural practice. And the MCW has had a rural central Wisconsin campus out of Wausau since 2016. And their focus is training primary care doctors and psychiatrists. You can move on. So we're lucky to be in a state that has fantastic rural training tracks. We have 24 rural training programs, including rural training tracks like the Baraboo program, which was the first in Wisconsin. There's also lots of urban programs with rural training options, like the Rural Health Equity Track that I mentioned and the Rural Pathway within our residency. And there's 8 targeted rural fellowships as well. Something I'm interested in is really understanding more about how experiences during residency, experiences around community health and leadership and advocacy help you become a more engaged physician in practice in a rural area, and how those add meaning to your work and impact your retention in a rural practice. Studies have shown that really the key factors that have kept physicians retained in rural practice relate to a sense of meaning and purpose around rural mission. So I think establishing that sense of connection to that purpose early on is critical. The Rural Training Track Collaborative, RTT Collaborative, is a national organization that supports rural training tracks and these urban rural training program options as well. And then we have a fantastic collaborative for rural GME in our state that supports those programs as well. So you can move on. So I mentioned RET and our rural pathway. RET started in 2017 through DHS funding, residency expansion funding to add 2 more slots to our Belleville class, each class. And what we do in RET that's unique to the Madison residency is that we facilitate more rural rotations. And then we support residents with rural community health experiences and advocacy experiences. We have targeted workshops that address equity issues unique to rural areas. We've done that on a variety of topics, and these are resident-led. They lead a full half-day workshop and bring in community partners, and they've been really outstanding. We attend national conferences around rural health issues. We're actually going next week to San Diego to the National Rural Health Association conference as a group with the RET residents and Rural Pathway residents. And they really lead the program. We have a steering committee, and the resident voices are the most important voices. So it's great leadership experience for them. This bar graph down here shows really the impact of rural exposure in residency. How many weeks you spend in a rural area has a direct correlation with choosing to go into rural practice. And so the Rett and Rural Pathway Program really target that 12 to 24 weeks in residency experience versus an RTT, which would get you more than 80 weeks. So you can go on. I think I've just got one more slide here. So it's great if we place graduating residents into rural practice, but retention is so critical. Rates of retention have not been outstanding historically, and there are great loan assistance programs like the National Service Corps. We have a state rural assistance program that helps to draw residents into rural practice, but too often we see burnout, and once your loan assistance expires, people moving back into urban practice. So just a couple things I'll note on here. Rural job placement, I think really the best resource is through the Wisconsin Office of Rural Health. They have a provider recruitment manager, Laura Ketterhagen, who I always encourage residents to email and talk to her about where there are jobs available and what scope of practice they're looking for, and prevents you from getting on an email listserv. Well, you'll get a million emails forever and ever. So I think it's just so important that we think about how we help sustain rural careers. So creating that sense of meaning and belonging in practice through community engaged work. A broad scope of practice has been shown to lead to more retention, so more likely to stay in rural practice. For instance, if OB is part of your scope of practice, being involved in teaching also adds that sense of meaning and belonging. Physician support and well-being really need to focus more on how we do this well. So making sure physicians feel like they have a voice in their organization, which is problematic in systems that are becoming larger and larger. People feel like they have less and less of a voice, especially in certain roles like making sure they can continue to teach and work with learners. Having effective teams in our clinic, scribe services, a reasonable call schedule are really important to retain rural physicians. And then some of those financial stability supports, as I mentioned, are really helpful. So I'll stop there. Happy to take questions later. Thanks.
Thanks, Dr. Landeck. That was excellent. Like I said before, if you have questions and you think you're going to forget them, feel free to put them in the chat. And we will turn it over to Dr. Anaya, who's going to talk about some pathway programs that she's been involved with outside of the state of Wisconsin.
Hi, folks. So Yohualli Anaya, I'm an associate professor in the department, and my research interests are specifically within physician workforce diversity. And so a lot of my academic and scholarly work has been in this area. And I developed this program that I'll kind of tell you a little bit about. So next slide, please. So my objectives today are really to talk a little bit about some of the core aspects that are key in developing pathway programs for specifically high school students that are URIM meaning underrepresented in medicine. And I'm gonna use this as a case example. Health career pathway programs exist in order to offer young people and students opportunities at the very kind of basic level. It's opportunities, whether it's a chance to engage in experiential learning or developing fundamental skills, receiving targeted support, other learning opportunities that are often in the health sector. Something that's really important for folks to be aware of, folks that are engaging in this work, is that while career awareness and motivation interventions are often the easiest to conduct, research actually shows that URIM interest in science and health careers already matches or exceeds that of non-Hispanic white students. And so the evidence tells us that what we really need and want to focus on is learning and opportunity, because that's where folks run into the most fundamental disparities, as Dr. Tellez-Giron was mentioning. So the Bridging the Gap program, which I founded, was developed with the ultimate intention of addressing the gap in representation of minoritized and low-income students in the health sector. And our vision was to do this through supporting students' skills in order for them to develop or to successfully pursue higher education and then hopefully health careers down the line. The program was initially launched at one high school and we expanded to 2 high schools. And I'll tell you kind of a little bit more about the specifics as we go along. Next slide. So this is the framework of our program. These columns in blue are our curricular pillars that the program was built on. This is all kind of evidence informed. So we went to the literature and looked to see like where are the needs based, where is the evidence based, and so we really built the curriculum and the program to address and strengthen these pillars here in blue. The program was created such that it was integrated into the residency curriculum, and the curriculum is delivered on a monthly basis at the high schools. It was specifically developed to be effective for disadvantaged and URIM youth. And we'll talk a little bit more about some of the kind of conceptual framework here. You can see that in the orange, it's called SET. But we specifically incorporate elements that are to develop skill mastery and increase student self-efficacy. And for the medical education component, we incorporated medical cases so that students could play doctor of the day and learn how it is that we approach a patient, really engaging them not only as learners, but also themselves as patients and family members of patients. And for this like sense of purpose, cultural awareness, the intention here was to incorporate components of leadership skills, community empowerment, and core concepts in structural and social determinants of health and the role that they, as future healthcare leaders, can play in their community. Next slide. And so these are kind of the basic components of a planning model for developing pathway programs. As you can see, and the main point here is this is a continuous and ongoing process. Evolution is necessary, evolution based on the needs of your students, on your evaluation efforts. It's central to pathway program development, success, and specifically your impact. As medical educators, we all know for a successful curriculum development really never ends. Rather, it continuously evolves based on our evaluation results and hopefully increasing resources. You're going to have changes in your targeted learners, et cetera. And so just kind of keeping in mind that our development programs need to continue to evolve and grow with our resources and our students. Next slide. So needs assessments, these are, I cannot stress to you how important these are. This is how we move from what we have as our vision to a set of common goals and objectives that reflects the population that you set out to serve. We want to prioritize the needs of our population, and we need to be aware of the context within which they're living and learning and growing. And if we don't perform a needs assessment, we can risk imposing incorrect assumptions upon our students. We can risk creating ineffective programs, worst case, potentially harming our students. And so it's really key that we perform needs assessments to begin with, and as part of our ongoing evaluation process, to be understanding our learners, understanding their learning environment, and really develop a curriculum that best suits their needs and their learning environment. This is also a great way to get buy-in from your stakeholders, for us, for the teachers, for the principal, really them realizing that you're doing this with their students, their school in mind. Next slide. And similarly to how we use evidence-based medicine, program development should be evidence-based. And to borrow a coined term from a pretty smart guy I know, he likes to say evidence-informed. And program development should be informed by the evidence. So in the past, selection of intervention strategies was not done based on evidence, and instead based on a program planner's instincts of what might work, approaches that were already familiar to them, what might be convenient or what might be easiest to implement. And the consequence can be ineffective programs in those scenarios. And so it's important that we use theory to be able to develop our programs that are going to be effective and that incorporate things that are already kind of validated in terms of learning. And next slide. And so for us, we selected a behavior change theory called social cognitive career theory because it provides a lens for how students develop their interests in an educational setting, and then how those interests pave the way for their academic goals and their academic choices, and then later on for their career goals and choices and their career achievement behaviors. This is just a visual of how it works. We're not going to get into the details of these theories, but really using the concepts of this or other validated theories is how you target some of those factors that are going to ensure the success and the outcomes that you're targeting. And so in this program, we target self-efficacy, outcome expectations, and then those socio-structural factors like financial aid prep and resources to really enable moving through from self-efficacy, success in goals, success in achievement behaviors. Next slide, please. And so really to kind of end with some best practices, programs that are going to be successfully assisting underrepresented minority students, they're going to be multidimensional. They're going to have factors that not only are going to address things like, let me introduce you to family medicine and primary care and how awesome it is to be a family medicine doctor, but also are going to have some of those other factors that we talked about, right? That are the either going to be what give them the skill development or the self-efficacy or whatever it is that we decide we are able to and the students are asking for or may need. They're going to be sustained. So, you know, really thinking about this from the very get-go, that our programs are built with intention and a sustainability plan from the very beginning so that we don't kind of go in and out of a school based on, you know, what circumstances we may or may not have. And this also, of course, is going to affect future stakeholder buy-in, right? If they've had folks kind of come in and leave and they've been burned before like that, they're not going to work with us and want to work with us in the future. And so this is also even just to continue to build partnership with your stakeholders. It's going to, these programs are also going to address those sociocultural contexts within which the students are learning and growing, just like Dr. Tellez-Giron was saying, right? Like there's so much else that's going on in students' lives, and we can't necessarily ensure success if we're not thinking about, considering, and in whatever ways we can addressing those other factors. Those non-academic barriers, for example, but the ability and knowledge that folks can access financial aid can be really powerful for students in order to ensure that they are able to progress down the academic pathway. Investing in your stakeholders and in your partnerships with your community organizations, really knowing that you are there as their partner and is going to go a long way, and that you're going to be there, and that again you're not going to kind of walk away when interest dies down or resources die down. And specifically as we think about sustainability and ongoing development. It's important that you continue to document outcomes and impact of your program. That's going to engage your stakeholders, and it's also going to engage the stakeholders on our academic side, right, to continue to garner support, continue to garner financial support. And as we think about larger institutions being sponsoring organizations, it is so important that funds are dedicated exclusively and specifically for assessment and evaluation. One, again, so that we're ensuring that we're actually doing what we intend to do, that we're actually helping and we're not harming our students, and to be able to continue to grow and develop our program so that, again, we can achieve what we really set out to achieve. So thank you, Tom, for having invited me as well. Really excited to share this virtual space with you all.